Do y'all have any other questions before we get started today?
I do.
Oh,
I have one more, sorry.
no, it's okay.
Our exams or our finals on next Monday, right? Or Tuesday?
Next Tuesday.
Are we gonna do like a review or like a study guide kind of thing?
Yes.
Okay.
We're running out of time, which makes me really sad. So what I want to do is kind of get y'all's opinion. I want to do a Kahoot for the review. If we can't play it during class, I'll at least share the link with you so that maybe you can play it online. But we've got, I think, 4 chapters left to cover, and we have a couple options. I can record those chapters like outside of class time and you can watch them on your own. And then we can spend the rest of class time going over case studies, the case studies packet, so that you can take your second attempt after we go over it together. And then do a final exam review. What do y'all think?
I like that.
We have 1 class period left. And honestly, the only other like important chapter that we have to go over is chapter 34, which you'll also cover a lot of that in special needs. The medical conditions will also be in special needs. So have you had that class yet? Probably not, huh? I'll focus on like the periodontal connection to those rather than teaching you about the medical conditions. So I can record all of those. Y'all can watch it. I'll make a handout for that chapter, for chapter 34, but honestly, probably not for the rest. You're going to learn about documentation as you go. You're going to take ethics. You have to take a jurisprudence, things like that. So the last really important things are today talking about maintenance therapy and then talking about the systemic link. So if it's okay with everybody, I can even schedule a time that works for you guys. If you want to, come to the lecture when I'm recording it, it's up to you, or you can just watch the recording. And then we'll spend Thursday, going over your case studies so you can submit your second attempt and get a higher grade, and then reviewing for the final exam. What do y'all think? If you are opposed to that, please send me a private chat so that I know and we can make arrangements for you to come to the live lecture, okay? All right, let's get started for today. So periodontal maintenance, why is this important? Why is this a whole chapter in the book?
Because people are going to have perio.
Lots of people have perio. This is like half our day is perio maintenance, right? If we've arrested disease with non-surgical periodontal therapy or surgical periodontal therapy, we have to maintain that periodontium for the rest of their life. What's the life expectancy now? Last week we said it's near 100. So if people have perio in their 20s, we've got 70, 80 years to maintain that periodontium. You only get 1 set. Here are your objectives, but here's really what we're going to talk about. So first, our introduction to periodontal maintenance therapy. Does anyone remember what a perio maintenance code is? That's okay.
It's
not really
4910.
Yeah, 4910. Good. 4910. That's a perio maintenance. I'm not going to test you on the code, but I think it's important to know as you go out into practice and your treatment planning in the clinic. Any patient who has had a periodontitis process in their life, treated or not, should be considered a periodontal maintenance. Of course, we're going to run into issues with insurance, but during school, there's no insurance involved. You can tell the patient what they need. So a periodontal maintenance is basically our continuing care appointment, our recare appointment to help a previous or current periodontitis patient maintain health after completion of therapy. We have to note that this term specifically only applies to patients with periodontitis or previous periodontitis. We don't use periodontal maintenance for a patient in health or a patient with gingivitis. This is only for periodontitis. And we usually only use this once we have disease stability. So how do we know if we have disease stability? What are some things that indicate disease is stable?
The pocket's not deepening after a 6-month recall.
Good. Pocket depths. What else? What are we trying to maintain? Gingival health, right? So even if we have a reduced, periodontium, we need gingival health. That's what we're maintaining. What indicates gingival health?
Inflammation.
Okay, so absence of inflammation, which includes bleeding, edema, redness of the tissues, things like that. So we're maintaining gingival health. We're trying to prevent future attachment loss. That's the big deal with periodontal maintenance. So description, this basically is anything that we do to keep periodontitis under control. What kind of disease did we say periodontitis is? Is it a constant disease, an episodic disease? Which one?
Episodic.
It's episodic. So we have to make sure that if the patient is experiencing an episode of periodontitis, we get it under control quickly. So this is why we actually see periodontal maintenance patients a lot more frequently than patients who are periodontally healthy. We have to have regular maintenance appointments. If patients are exhibiting a decrease in self-care, this is really important. When we tell patients that they have periodontitis, we have to let them know this is a disease and you could potentially lose your teeth. You don't have to be alarmist about it, but they need to know that. Otherwise, they don't understand the importance of it. Our goal is always to prevent recurrence of periodontitis and maintain what the patient has left in the mouth, maintain the current attachment levels. So here's a little chart from your book. I love this. Patients who underwent periodontal therapy and did not attend regular maintenance appointments, we were seeing up to 1.2 millimeters of additional attachment loss, even after NSPT. Patients who attended their maintenance appointments were regaining some attachment. How did they regain that attachment? What is that from?
Could it be like a pseudo pocket?
Could have been a pseudo pocket. But if we get healing in NSPT, it's from the formation of
Isn't it long junction epithelium?
good long junctional epithelium. How many millimeters do we expect for healing with the long junctional epithelium?
1 to 2 millimeters.
1 to 2. Good. Very good. And y'all will start to see this when you have periodontitis patients in the clinic and you bring them back for a 4 to 6 week reeval. I know it's tempting to reuse their perio chart from last time and think you can get away with that, but the whole point of a reeval is to recheck every single site and make sure that the patient is stabilizing. So this is what you will start to see with your periodontitis patients. The importance of this, basically, perio is a chronic disease. It's never cured. The bacteria is always present in the mouth. So we can control this, but we can't reverse it. That's an important thing to explain to our patients. We can control your disease and stop it where it's at, but we can't reverse the process once we get into periodontitis. A lot of patients with periodontitis, disease recurs, there are a lot of different factors. Remember talking about the host factor. If a patient is stressed and their immune system is lowered, they could have a recurrence of periodontitis. There's just lots of different things that can go into this. Vigilance by the dental care team. This means encouraging the patients to come to their regular 3-month appointments. And you and I are the main providers right now. The dentists don't really have a whole lot to do with periodontal maintenance. It's you and I. Perio charting, removing deposit, removing plaque. These things are all really important for perio maintenance patients. What are the goals? Basically, minimize recurrence and progression of periodontitis. What are some secondary risk factors that we've talked about that need to be controlled? Let's start with what's the primary etiology?
Plaque biofilm.
Yeah, plaque biofilm. Do y'all think I'm like here to trick you? I'm not. We're just reviewing a little bit. It's all right. Plaque biofilm is the major primary etiology. So what are some risk factors that cause plaque retention and therefore more perio?
Smoking.
Good. Smoking. What are some of those local factors that retain plaque biofilm?
Morphology.
Morphology. Good. I'm just going to write morph. Overhanging restorations. So all of these things need to be addressed at every single periodontal maintenance appointment. What happens if a patient has periodontitis and they never get it treated? What happens to the teeth?
It'll eventually be unhelpable.
Yeah, they'll just fall out eventually, right? The teeth will fall out. There's nothing left to hold them in besides calculus usually. So we want to increase the probability of detecting early disease so that we have a really good hold on it. The expected outcome of this goal is basically to help the patient keep their teeth throughout their whole life. Wouldn't it be cool if we got a third set of teeth that came in like our 50s or 60s? Yeah, but we don't have that. So we have to maintain what the patient has left. What is our role in this? We have to have active participation. And I want you to notice the patient is part of this. You cannot do this on your own. This isn't something that you can take on your shoulders and feel responsible for. The patient has to take care of their part of this. The dentist, yeah, I love dentists, don't get me wrong, but y'all are doing the legwork here. This is the hard work that's being done. The dentist is very helpful in reducing those secondary factors like overhangs or poor crown margins, things like that. But at the end of the day, we have to fit each individual patient need. And that's going to be different depending on every single patient. So following NSPT, we have to reevaluate the patient's periodontal status. This is what we call a reeval. We wait how many weeks minimum for a reeval? 4 weeks. Why?
To let it
Let what heal?
the periodontitis.
Specifically, what tissue?
What's
The junctional epithelium? Good. The junctional epithelial cells cannot withstand probing prior to 4 weeks. So reevals always have to wait at least 4 weeks post-treatment. Basically, we redo the whole appointment. We start from the beginning. We go over everything from the beginning, reprobe the patient, calculus detection, EO-IO, all of it. This is usually where periodontal maintenance begins. This is for patients who've had adequate response. If they have not had adequate response, we may need to send them to perio or consider surgery. Here are some phases of periodontal therapy. I'm not going to ask you about this. I just like the colors of the chart. So steps in the appointment. This is what's going to happen. First and foremost, at every single appointment, we are updating the patient's medical history. How often should patients fill out a completely new medical history?
Once a
Is it
year.
once a year?
Once a year. But if you're seeing a periodontal patient every 3 months, you're seeing them 4 times a year. So we're just updating what they have at 3 appointments, and then at the 4th, asking them to fill out a new one. So let's talk about medical status. Systemic diseases. Which systemic diseases are we specifically looking for that relate to perio?
Diabetes.
Diabetes, good. What else?
Cancer?
Cancer,
HIV?
good. HIV,
Cardiovascular disease?
good. CVDs, what about some conditions that may not necessarily be considered diseases? Think about your ASA classifications.
Hypertension.
Okay, hypertension. What else? What are some other inflammation triggering conditions?
Would osteoporosis be?
Yeah, osteoporosis for sure.
People going through hormonal changes like pregnancy or teens?
Good. And menopause, like the osteoporosis connection there. Obesity, remember we talked about obesity and the level of inflammation in the body being increased. Patients under psychosocial stress. All of these things go into our treatment of a patient with periodontitis that's stable or not stable. I want you to think of any disease that increases the amount of inflammation in the body lends to the process of periodontitis. So any autoimmune disease, any host response modulation, anything like that relates back to periodontitis. How about medications? There are 3 medications off the top of your head I want for gingival enlargement. What are you thinking of right away?
Dilantin?
Dilantin, otherwise known as phenytoin. What else?
Cyclosporine.
Good. Cyclosporine. And 3. It's a calcium channel blocker.
Procardia?
Procardia. Good. What's the generic? Nifedipine. Nifedipine. So those 3 for sure would trigger us to think about, ooh, something might be going on here. What other medications? What are some common side effects of medications you know about already?
Dry mouth.
Dry mouth, xerostomia, that contributes to perio, right? Anything else?
Halitosis?
Halitosis, yes. Those volatile sulfur compounds. Pretty much any drug that causes xerostomia is going to make plaque more retentive in the mouth. Immunosuppressants cause a lot of issues. Pretty much all medications cause xerostomia. The big outliers are ibuprofen, aspirin, those cause GI upset more frequently. And then we need to think about antiplatelet drugs as well. If patients have an overreactive bleeding response due to taking something like warfarin or Plavix, that doesn't necessarily indicate that they have active perio. They may just have an overreactive bleeding response due to a medication. So are these classes starting to like come together and make sense now? Why you had to learn about all these separate things? Now we're starting to put them together when we think about treating a patient, right? So social history, lifestyle. I have had so many patients who, following the death of a loved one, have literally stopped brushing their teeth, like could not get out of bed, weren't doing anything for themselves. Grief is very, very significant in health. Work status. I mean, how many of y'all are so busy right now? You're like, when am I going to do this? When am I going to do that? Right? Work status. That's a huge thing. Work status also affects whether or not the patient can afford to seek dental care regularly. Dental status. Is this patient going to another office? Either a perio office, a specialty office? Did they try another dentist office and decide they didn't like it and come back to us? Medical status, medications, update all things, all the things. And then the patient's perception of their oral health. Are they realizing that this is a chronic disease and that they need to do their part at home, or are they pretty about it? They just, I don't really care. Clinical assessments. Just looking at this radiograph first, tell me what you're seeing on this radiograph.
Restorations.
Restorations, extensive restorations, yes.
Bone loss.
Definitely some bone loss.
You can see the maxillary sinus.
Definitely. The maxillary sinus is very close to those maxillary molar roots. Can you see here? It looks like we've got an issue with this crown margin. It's not very nice. We've got all this loss between the crown margin and the alveolar crest. So it's probably packing plaque in that area. So clinical assessments. This is us looking, doing our periodontal assessments and radiographs. The steps, y'all know the steps for an appointment. It's the same as any other appointment. In our periodontal maintenance, we really have to look at probing depths, bleeding on progression, and bleeding on probing, and then attachment levels. If we're seeing an increase in clinical attachment loss of 2 millimeters or more, that is considered to be true progression of periodontitis, and that patient probably needs to see perio. Furcation involvement, you know, you and I have a hard time cleaning furcations. The patients really can't clean that. Moving forward to self-care evaluation, what are some tools you already know about that you can use to evaluate whether the patient is taking care of their oral health at home?
How do we tell if they are? I guess if they've gotten better since the last appointment.
Yeah, if they've had gain of attachment since the last appointment. How about disclosing solution? And a plaque score. That's really going to tell us how is that patient doing at home. I don't know if y'all are allowed to do this in your clinic. I love disclosing my patient, doing my plaque score, and then asking them to brush without a mirror and seeing how much they have left after they brush and showing them, you only reduce the plaque this much and we need it to get closer to 0. So these are some tips that I can use to help you get to that 0 for your plaque score. Is it possible to get to 0? No, but it's our goal. It's what we're working toward. Always inform the patient. Positive reinforcement is huge here. And then again, disclosing solutions. Some patients respond really well to this and will actually take disclosing tablets home. And it's a great home care tool for them to use. Identification of treatment needs. Do we need local delivery of antibiotics? So in this case, Arrestin. When would we use Arrestin?
5 millimeters more.
5+ millimeter pockets. We should automatically be thinking about Arrestin. Does the patient need restorations in the mouth? Do we need to do another scaling and root planing? What do they need going forward to return them to gingival health? Instrumentation. I don't want y'all to ever think of a perio maintenance as like an easy appointment. It is not. It's not easy at all. We really have to conserve the root surface. It's very easy to gouge cementum and remodel the shape of roots, especially in the mandibular anterior. So ultrasonic instrumentation is really important. Plastic curettes. I don't like plastic, but they recommend it. There are also the handy air polishers now, the airflow handy or whatever they're called from Hugh Freedy, that have erythritol powder that's great for patients with perio maintenance. Patient counseling. Always go over tobacco cessation. What do we say when the patient's like, I don't need to hear about it again?
It's our job.
It's our job. I pride myself on doing my job well, and it is my job to educate you on this. You don't have to take my advice, but I do have to give you the advice. Smoking cessation, double down on home care, make sure they're doing what they need to do. Other risk factors, systemic health is huge. You and I have every reason to recommend that our patients go to their regular physician appointments at least once a year. Blood pressure, glucose levels, all of that's really important. And then nutritional counseling. What are some nutritional deficiencies you remember talking about that lend to periodontitis?
Vitamin C,
Causes?
scurvy.
Scurvy, yes, that's my favorite. Thanks for remembering. That's my favorite, scurvy. There are also protein deficiencies. You'll talk about this more in nutrition, but a lot of nutritional deficiencies impact periodontitis. And then application of fluoride. Why do we use fluoride, especially for patients with perio maintenance?
Sensitivity.
Sensitivity created by exposure of the root surfaces to the oral cavity, right? So remineralization of root surfaces, prevention of root caries. Do root caries progress faster or slower than caries on the enamel?
Faster.
Faster. And patients with periodontitis may have already had a lack in home care. So we need to let them know about root caries. Decisions. Who do we treat in the general office? Who do we treat in the perio office? Mild periodontitis patients can usually receive routine perio maintenance in the general dental office. This is something you'll see all the time. Moderate periodontitis, usually we do alternating appointments, so every 3 months. At one, they'll see us, the next they'll see perio, us, then perio, as long as they remain stable. If they have severe periodontitis, we're probably going to just flip them right over to the periodontal practice. Same with aggressive. We can't really control aggressive processes. I think it's really funny that they left these words in because they're not really used anymore, but they haven't updated all the textbooks yet. So mild periodontitis, this is a patient with like 1 to 2 millimeters of loss. Moderate is 3 to 4 millimeters of loss, and then severe is 5+ millimeters of loss. What are the aggressive periodontal diseases that we recognize now in the 2018 AAP? Necrotizing. Do necrotizing diseases move faster or slower than chronic perio processes? Faster, good. Maintenance intervals. This is really important. This applies to your practice as a new hygienist and to the board exam. We can never say all perio patients need to be seen at every 3 months. It's up to each individual patient. So let's talk about an example. A 24-year-old patient with slight periodontitis and moderate compliance with home care. What is your recommendation for a recare interval for perio maintenance? I'm seeing 3. Everybody agree? Okay, 3 months. Good. How about an adult, I don't know, let's say mid-40s with 1 to 2 millimeters of attachment loss and impeccable home care? What do you think we could do for them? Why don't we go right in the middle of the 3 and the 6 and say 4 months, because we still have to make sure they're not progressing. Remember, they're more likely to have reactivation of periodontal disease. So 4 months is probably the best decision for them. 6 months, it's really, I hardly ever had patients on a 6-month recare for perio maintenance. It's usually 3 or 4 months, but there are always extenuating circumstances. What did y'all think about the, go ahead.
I'm sorry.
It's okay.
So for somebody who had moderate home care, but they had or even good home care, but they had a systemic disease, would they be like 1 month other than like instead of 3 months, or?
It depends on what the disease is. That's a really good question. If they had something like HIV, yes, 1 to 2 months would be helpful to keep them from getting opportunistic infections in the periodontium. If it's somebody with a disease like cardiovascular disease like hypertension, they're probably okay at the 3 months. Very good question. What did y'all think about the case study for Lewis? What would his recare be?
I put 4 to 6 weeks.
Okay, his reeval is 4 to 6 weeks. And if at the reeval, we notice he's still not brushing, he's gone back to smoking, what's his recare interval at that point?
But it's not still be 4 to 6 weeks.
It's probably going to be a month at that point, 1 month, because he's not compliant, right? I'm not saying that's the answer for the case study. We'll talk about that Thursday, but all these different things will change your maintenance interval for each patient. So periodontal disease recurrence, we know this happens. Here are some of the clinical signs. We've talked about this before. Periodontal patients are always at risk for recurrence of disease. We're talking here, recurrence means that the patient has been successfully treated and stable, and then periodontitis reoccurs due to a number of different issues. So here are some of the reasons for recurrence. It could be self-care. It could be leaving residual calculus could cause reactivation of disease. Failure to control local factors like the overhangs and the crown margins. Inadequate control of occlusal factors. If the patient has traumatic occlusion and we don't do something about it, that could cause issues with their periodontal status. improper surgical technique, which you and I don't have anything to do with, and then attempting to treat teeth with poor prognosis. I am a hopeless optimistic. I would rather treat a patient and see if we can save anything instead of giving them full dentures if at all possible, but we have to be realistic about teeth with poor prognoses. Can we save them? Probably not. Is it worth it to try? That's up to the patient and the surgeon. Now, recurrence is different from refractory. Refractory periodontitis is resistant to treatment. It's like we never got control of the perio. So recurrence is when we get control of it and then something happens to make it come back. Whereas refractory is we're having a hard time getting a handle on it. It's never been stable from the beginning. Management of patients. Sometimes we have to retreat and do another scaling and root planing. If any of you have already worked in a dental office, you know that insurances are very finicky about paying for scaling and root planing. So if they have to be retreated within a certain amount of time, their insurance may not cover it. Reinforcement of home care, importance of their maintenance appointments. This happens all the time. I only want what my insurance pays for. Well, your insurance pays for a pro fee, which is for a healthy patient. And if you had taken care of your teeth, you could have gotten one of those, but you didn't. So now we're into perio maintenance, right? Don't say that to your patients. Don't go to school and tell Miss K or Miss DePaul that I said that to say to your patients, okay? Sometimes we might have, again, local antibiotics. If we have generalized attachment loss, sometimes surgical intervention is necessary and we need to get them over to a periodontist. Patient compliance. Have y'all experienced this yet? Patient compliance. Love it. Love it. I had a patient named Rosie. Rosie was morbidly obese and had hypertension, hypercholesteremia. She had a lot of health issues and she didn't brush her teeth. She said she just didn't feel like it. So every time she came in, her teeth were coated in plaque and food and like whatever she had eaten that day. Rosie, to this day, is my most non-compliant patient. I have never seen anyone with worse compliance than her. And then you have patients who are also in the dental industry and they're so compliant. You're like, you could like chill out. You don't have to floss 3 times a day, but they're doing it anyway. So patient compliance is different for every single patient. Basically, if they're compliant, they're adhering to your recommendations. If they're non-compliant, they're not. Does anyone have examples of non-compliance? How about smoking after an extraction? Happens all the time. That is non-compliant behavior. So there are a lot of different things that can go into non-compliance. Okay, sometimes patients are really afraid of the dentist and we have to be aware of that. We have to make them feel as comfortable as we can. And I can't tell you how many times somebody's going to walk into your op and say, I hate the dentist. I hate being here. Don't take it personally. They probably had a poor past experience. Expenses. Dental care is expensive. That's just how it is. I wish there were better options, but then we would make less money. So what do you do, right? Catch-22 in that situation. Patients who have a low priority for dental care. We've talked about some cases where like a young mom of 2 kids is staying at home with her kids. What priority is her oral health? High or low? Super low. Yeah. Denial of a condition. With the advent of corporate dentistry offices, there's been, don't get me wrong, I don't have a problem with corporations, but there have been a lot of cases in which patients were duped and, treatment plans were overdone. And it's not any one company that's guilty of this. It's happened all over the place, even in private dentistry. But due to corporations popping up, patients are more aware now and they're looking at their treatment plans, which they should have been doing the whole time, but here we are. Oh, that dentist just wanted my money. I'm not going to get a scaling and root planing. That's $750 per quadrant. I'm not doing that. Improving compliance. Why is the patient non-compliant? You know, there are children patients who you'll say, have you been brushing and flossing every day? And they'll say no. And you say, why? I don't have a toothbrush. They need a toothbrush. That was their barrier. That's why they can't be compliant. So we really have to be empathetic to our patients. That's a big thing. Send appointment reminders, text your patients and say, hey, you're due, you need to get in here, kind of thing. Printed self-care instructions. This is hard because every patient's going to be different. So we would have to type up and print a new one for every patient. And then positive reinforcement. When you notice that they're doing something well, praise them for it. Say, I noticed you're brushing closer to your gum line. I just wanted to tell you, great job. I'm so glad that's working for you. Things like that. Root caries. Check that out. I love when patients come in, they're like, my teeth are stained down here. I'm like, no, that's decay. But I can't say that, right? We can't say it's decay. So tooth decay on root surfaces of the teeth can only occur if we have exposure of the root surfaces due to a perio process. So active lesions look kind of yellow. Inactive lesions here, we've got that dark brown to black appearance. Usually this starts at the gingival margin, and the important bacteria here are the lactobacillus. These are commonly present in root caries specifically. Now, the critical pH for enamel, does anyone know the critical pH for enamel? Critical pH when 7 is neutral. 7 is neutral. Critical pH is when decay starts, basically. When is demineralization beginning on an enamel surface?
So acidic, so I guess like 6.
Yeah, so for enamel, it's actually more like 5, like 4.5, 5. But for root surfaces, it's just below neutral. So these are much more susceptible to demineralization, which is why we have to keep a close eye on these during perio maintenance appointments. Risk factors, y'all know this already, I'm sure. Attachment loss, inadequate self-care, cariogenic diet, it's basically the same. Whatever causes caries on the enamel is also going to cause caries on the root surfaces. Prevention, prevent periodontitis. This is the best way because if we don't have exposure of the root surfaces, we can't have decay of the root surfaces. Fluoride, what kind of fluoride would you recommend in office for a patient with root exposure?
Stannis.
Stannis, why?
Sensitivity.
Maybe sensitivity. What's even better?
Varnish.
Sodium fluoride varnish, because it's actually bonding to the teeth. It has a chemical and physical bond. So varnish was actually FDA approved for sensitivity, but it's also anti-caries. So varnish is amazing. I think it's the best. We can also recommend xylitol products. Do you know how xylitol works? Have you learned about xylitol yet?
I know about it just because I work at a holistic office. But
There
I
you
know
go.
that doesn't it remineralize instead of, it's kind of like fluoride, but it's not.
Kind of, yeah. So what happens when patients use xylitol products is the bacteria in the mouth ingest xylitol, but they're not able to metabolize it. So the bacteria die and then can't cause disease. So xylitol is a really cool product, especially for people who are anti-fluoride. You can recommend xylitol, and those products are all over now. And then again, adequate home care. Is the patient brushing? What would you recommend for home care for a patient with recession due to periodontitis?
Sensodyne.
Okay, Sensodyne. How about a toothbrush? What kind of toothbrush?
Power toothbrush or soft bristle?
Good. Power toothbrush with soft bristles, yes. How about interdental aids?
Water irrigator.
Okay, water irrigator. And usually for patients with periodontitis, if we have loss of the papilla, if there's an open embrasure space, we need to start considering something other than traditional floss. We might need tufted floss. Has anyone tried cocoa floss? Oh my gosh, you guys, try it. It's amazing. Do you like it, Bailey?
I used it once. My sister gave it to me. I like it, but I just went back to the normal floss though.
The easier one, yeah. It's like it's thicker and it really grabs onto plaque. I love it. I'm obsessed. I just got my first order of it. So it works really well. It takes a little longer, but it works really well. All right, any questions from this chapter for today? Okay. I just want to show y'all real quick. I got this cool little thing from Kilgore to help you understand the different phases of periodontitis. Can you see it? So this is a cool little model of like what it looks like during health, during slight disease, moderate, and you can actually, these teeth are like mobile. And you can depress them and everything. So this is a really cool thing. I'm going to take a picture and put it on Canvas for you guys, just so that you can see, you know, what does it look like? What are we actually seeing for bone loss in these different areas? I'm just so excited about this. I love this thing. And then I want to go over some instrumentation techniques for perio, because I think that your book didn't really cover it very well. So when y'all look at your typodonts, right? If you wanted to clean the distal surface of number 18 with a 5mm pocket, what would your best instrument choice be for that? Distal of number 18, if we had a 5mm pocket.
Montana Jack.
Subgingival.
13, 14.
The 17.
Okay, it's 1718. Thank you, Lexi. Because the 1718 has an extended shank and can therefore reach to a 5mm pocket, to the base of a 5mm pocket. Good. Let's see. Have y'all learned about mini Gracies yet or any of that? Okay, a lot of times when we talk about perio patients and you think about the mandibular anteriors, can you reach 5mm with a standard Gracie 1-2? What might you need? These are called minis, a mini Gracie curette, and they can actually reach into some pretty small areas. What other areas exposed during perio do you think might be helpful using a mini curette? What do you think?
Maybe the premolar.
Premolars, yeah. And what else is exposed that we might need to clean? Very small area. Furcation involvement. We might need a mini curette. So it's a really small working end. What does a greasy after 5 mean? After 5 is just signifying that the instrument can reach into 5mm pockets. It's got a longer extended shank. So those are just a couple of periodontal instruments I want y'all to be aware of in case you ever see them on a case. Because I don't think that I will see y'all again until board review. So let's go over one more PowerPoint. This is a quick one. And then you're free to go for today. Oops. Motivational interviewing. Have you already talked about this before? Nah. Okay, motivational interviewing. A lot of this sounds like common sense, and it's things that we know, but we don't necessarily know how to put these into practice when we're talking to our patients. So this has a lot to do with psychology, behavior, human behavior change. How many of you have siblings or kids or even, I don't know, parents, friends who you try to get to change a behavior? What's your pet peeve? Everybody tell me your pet peeve. What behavior is your pet peeve?
Leaving trash around.
Okay, so
really
not
bothers
picking
me
up
'cause
after yourself.
Yeah, and then like more than likely you're always gonna walk by a trash can, especially
Yeah.
outside.
I agree. In my little town that I live in now, outside of Dallas, there are trash cans in the medians on the roads so that you can throw out trash from your car into the trash cans. Love it. Don't mess with Texas. Okay, pet peeves. What else, guys? Anything?
Not making the bed.
Not making the bed. Okay. What else?
Sticking your
Come on.
gum on your plate.
Sticking your gum on your plate. Ugh.
Hate that.
People who bite the fork and you can hear it.
Oh my gosh. My husband does that, and he has literally chipped both maxillary centrals, and he keeps doing it. Yeah, that drives me crazy too. What else? This is fun. Come on, share.
Chewing on stuff. Like I remember a whole bunch of boys in high school, they would always take the caps off of the Milo sweet tea and just sit in class and chew that. It drives me
Ugh.
crazy.
Yeah, ew. Anybody else want to share? Just air your grievances now. When teachers make jokes that aren't funny, guilty, sorry. Okay, so if you recognize this behavior and you really want to bring about positive change, how would you go about that? So Megan, do you say, throw away your freaking trash or I am going to kill you? Does that work? Depends on who it is, right? It's not very motivational. That's kind of like, I'm going to run, fight or flight kicks in, right? Moana, when you see a bed that's not made at your house, what do you do?
Well, first of all, I tell them either you make the bed or you go somewhere else and make your own bed.
There you go. Okay, so we have to figure out how to bring about a behavioral change in a positive manner so that patients don't hate us, right? Are patients more likely to ask to come back to you if you say, I wish you would brush your teeth because you got stank breath real bad? Or if you say, can I help you improve your oral health? Can I teach you some tips and tricks to help you improve your oral health, right? So it's all about how we word these things. Sometimes it's like we have to make it the patient's idea, almost make them think it was their idea in order to get a change to be brought about. So improved oral health requires a behavioral change on the part of the patient. Influencing patients to change can be very difficult, very, very difficult. Sometimes they're resistant because of their attitude, like they don't want to be talked at. They want to be a part of their decisions. They want to be a co-therapist. They may not believe that their oral health is important, and it's really hard to change a habit. How many of us have bad habits? I chew on my nails, and it's disgusting because there's so much bacteria on our nails, right? Anybody want to share your bad habit? You don't have to. I'm just curious, being nosy.
I bite my lip.
Too.
Bite your lip, nails, bite your cheek. Some of you text during class. That's fine. I see you. All right, current circumstances. Patients may not have the time, the money, or health literacy. Health literacy basically relates back to, does the patient understand why this is important? You'll hear patients say, nobody ever explained to me how I'm supposed to brush my teeth. And it's true. Nobody took the time to go over that with them, so they didn't understand. Confidence and then building new skills. This is a big thing. Patients don't like to feel inferior, so we have to be really careful about talking down to them. How do y'all like it when somebody talks down to you? You don't. I already know. I already know. Makes you upset, right? Well, we don't want to do that to our patients. So we have to talk about motivational interviewing. Motivation. You can do this, right? That's what I tell y'all all the time. You can do this. Keep your chin up. Keep a positive attitude. So this is basically a patient-centered method. We want to enhance motivation for behavioral change by talking to the patient and figuring out what are the barriers to you doing this practice. And in this case, it's oral healthcare at home. So what is our goal? We want to understand the patient's point of view. We have to attempt to encourage healthy behavior, and we're guiding the patient instead of ordering them around. So tell me some examples of things you shouldn't say about home care. Tell me some things that would not be included in a motivational interviewing process.
You have bad home care.
You're bad at this. Yeah. That's demotivational, right? What else? What has somebody said to you about a habit that you were like, I don't care what you say because that was rude? Anybody here have Primnesia? You order things on Amazon and then you forget about it and it arrives and you're like, oh, I ordered this. Anybody else guilty of that? Yeah. So my husband will say, Amanda, you've got another Prime package? And I'll be like, you keep saying that, I'm going to keep ordering it, right? Instead of saying, maybe we could look at the cart together before we buy it next time, right? There are different ways to go about this. And that's what you and I really have to explore with our patients. So focus on the patient's internal motivation. What will get them to brush their teeth? What is the internal motivation of a 15-year-old boy?
Kissing girls.
Kissing girls. Boom. What's the motivation of a 45-year-old man? Money? I don't want to pay for a scaling root planning. What are you going to say, Callie? There's no right answer.
I was going to say, if he's divorced, kissing girls.
Yeah, kissing girls. Yes. Okay. How about a 13-year-old female? What might her motivation be?
Maybe a nice smile.
A nice smile. Good. So we're already identifying potential motivation for patients, and it's going to be different for every single patient. So what are the components here? Partnership. We are not lecturing our patients anymore. I'm lecturing you so you don't lecture your patient, right? So we have to avoid the role in which we say, well, it's my professional opinion that you need to brush twice per day. How condescending. Let's work with the patient, set some goals, and really get them involved in their own oral care. Acceptance. We have to accept our patient as they are. We can't change them. Have some compassion. Really, this is going to take you a long way with your patients, having compassion for their circumstances. And then evocation. This is basically like, we want the patient to come to the realization that a change needs to be made. And the only way to do that is by letting the idea come from them. Responsibility. Read this, read it again, read it one more time. You are not responsible for your patient's decisions. You cannot take this personally. You cannot take this on your shoulders. Unless you plan on going to visit every one of your patients at bedtime, after meals, and in the morning when they wake up, you cannot take responsibility for this. At the end of the day, all you can do is ask the questions and give them the information that they request. Avoid yes or no questions. Do you brush your teeth twice a day? Versus, how many times a day are you brushing your teeth right now? Do you floss once a day? Do you use dental floss? Don't even ask how often, because patients will lie to try to give you the answer they think you want. Ask open-ended questions and get them talking. How do you feel about flossing? Do you feel annoyed about it, right? Encourage the patient to really elaborate on their situation so that you can understand their perspective, and then make recommendations based on what they say. One thing we hear a lot, I don't have time to floss. Let me ask y'all something. How's the traffic in Nashville? I was there last week. I know how the traffic is. Patients who are sitting in traffic can easily use a floss pick while they're sitting in traffic. Patients can easily use a floss pick at their desk after lunch. That's their one time a day, right? So incorporate it into whatever they're doing throughout their day to make it easier for them. Reflective listening. Check that you're getting their message right and back off. Sometimes you just have to back off. Do your job, but don't push patients to the point where they hate you. We're always moving towards patient-centered care. Whatever we can do to help the patient remain healthy is what we need to do. And then affirm the patient. Let them know, hey, you're doing a really good job with this. Or I really appreciate the time that you're taking for your oral care at home. Things like that. You would be shocked how much positive reinforcement motivates patients to brush and floss at home. How about you guys, when you come to me with a problem, right? And you say, this quiz answer is incorrect. And I say, I'm not going to look at that. Have I ever said that? I'm not going to look at that. Right? We have to ask open-ended questions to each other. Otherwise, we don't understand the needs. So in this case, it's teacher to pupil. But I still ask for your help, right? I'm not the expert role. I ask you, what do you need? And you need to do the same thing for your patients. Summarize, reinforce everything, provide information, get the patient what they need. Do they need an electric toothbrush? Sometimes the novelty of it really, really reels patients in, and it might help. Inquire what the patient already knows and then build on that. Only provide relevant advice. Don't go off on a tangent like I do every day. And then provide your patients with research. Always back up your opinions with research. This is what's important. Motivational interviewing, we need to be engaging. We need to be focused. We need to evoke emotions that motivate patients, and then plan. We have to make a plan. This is where written instructions come in handy for patients. And that is it for today. Does anyone have questions or examples, or do you want to share anything about motivational interviewing? Nothing? Y'all tired? Okay, so I will plan on tomorrow, I will record the lecture with the remaining chapters. And then on Thursday, we'll review the case studies in depth. And I want everybody to bring your case studies either online or on a piece of paper so that we can talk about them in depth and you can take your second attempt at the quiz. So if you can, please take your first attempt before Thursday, okay? You will not receive the final grade on your first attempt. We will talk about it and then you'll have another chance to enter your answers, okay? Okay, you know where to find me if you need any help. And if you don't, I will see you Thursday. Thank y'all for coming today.
Miss Mitchell,
Yes.
were there handouts from today?
Nope.
Okay, just wanted to
Too
make
much
sure.
discussion. There wasn't really a lot of like fill in the blank for these things. It's really more like, how do we talk to our patients about this?
Okay, thank you.
You're welcome. Thank you.
Miss Mitchell,
Yes.
I signed